Good afternoon, and welcome to this faculty panel, Healing in the Professions. I'm Pastor Jen Rude, and I serve PLU as the university pastor. As we begin, I'd like to acknowledge that Pacific Lutheran University sits upon the traditional lands of the Nisqually, Puyallup, Squaxin Island, and Steilacoom peoples. We acknowledge, respect, and send gratitude to these traditional caretakers of this land and this watershed, communities who continue to be leaders for justice in our communities today. As we enter into this conversation about healing, I am also mindful of the brokenness and suffering in Ukraine. Those who are impacted by violence, fear, displacement. And I'm also mindful of those perpetrating violence as their spirits and bodies act out of their own brokenness. The prophet Isaiah in the Hebrew scriptures, which are shared by Jews and Christians, casts a vision and declares God's command. They shall beat their swords into plowshares and their spears into pruning hooks. Nation shall not lift up sword against nation, neither shall they learn war anymore. May this learning and God's peace come quickly. Before I introduce our first speaker, just a note to please use the webinar's Q&A function to ask a question at any time during the presentations. And then after our three speakers share this afternoon, we'll pose these questions to our panelists. So we begin with Dr. Jodi Erickson. Dr. Erickson is assistant professor in the PLU School of Nursing. She's been a nurse for 10 years with a background in ICU and end-of-life decision-making. You can read Dr. Erickson's full bio on the event webpage. And today, Dr. Erickson will be sharing about how older adults understand the term allow natural death. So welcome, Dr. Erickson.
Thank you so much. All right, I am going to share my screen. All right, so good afternoon. As Pastor Rude said, my name is Jodi Erickson, and we're here today to discuss healing. Before I get started, I wanted to thank the Wong Center for inviting me to be here today. It's really a great honor to be amongst the speakers for this event. We're here to discuss healing, and I'm going to talk about death, which may seem like a disconnect, but bear with me. As I've been listening to the wonderful speakers the last couple of days, I've noticed a theme in storytelling and the power of sharing stories. Because of that, I'd like to share a story of what drew me to focus on my work on end-of-life decision-making as a way to bring understanding to the need for this work. So, as Pastor Rude said, I'm a relatively new nurse. I've been a nurse for about 10 years. Before becoming a nurse, I spent 2 decades of my career working with older adults. Early on, I worked with people who had Alzheimer's disease. And for the last 8 years before going to nursing school, I ran a membership and volunteer program for people ages 55 and better. If you've ever worked solely with volunteers, you know that a big part of that work time is spent talking and sharing and drinking coffee and eating the occasional donut. So I remember sitting at a table full of these people who were wise and kind and hardworking, and they would talk about death. One day, shortly after a long-time volunteer had passed away, we were assembling a mailing, so we were stuffing envelopes, applying labels, drinking coffee, and, we were eating donuts. And I overhear Jerry say, Joan died the right way, asleep in her recliner, peaceful and calm. Everybody agreed. And then the conversation turned to how people did not want to die. They talked about their friends who died in the ICU, all hooked up to tubes and lines, possibly having heroic measures such as CPR done to their bodies. I listened to these people for whom I had great respect, and I listened as they shared their wishes in this safe, comfortable, donut-filled space. Now, fast forward to October 2011. I'm a brand new nurse working on the ICU. In my mind, before I went into nursing, I thought that it was just young, healthy people who were in the ICU. I thought it was people who were just walking down the street and suddenly they had some sort of life-changing event where they dropped to the ground, someone called 911, and they were whisked away to the local hospital's ICU. What I found out during nursing school is that the majority of patients in the ICU are indeed older adults. So as a brand new nurse, I was working on a floor filled with people in the age range that I loved, and I was witnessing people die in a way that I felt my volunteers would have hated. The first time you do CPR on an elderly person and you feel their ribs break under the force of your hands, while you understand it logically, it's really hard to process. So I realized through my experience that when communication occurs, there can actually be healing in death. And when we lose someone, we're sad naturally, but we don't have to feel distress. So now fast forward to June 2014, as I started my doctoral work, it became natural for me to dive into the literature and try to find a way to influence how people die in order to bring them healing instead of that pain. This brought me to the study I'd like to share with you today. I want to say too, I did pick these pictures because one is someone I love dearly in a chair with rowdy grandsons. And the other picture is someone I love dearly, the same person who was in the ICU. So I wanted to give you a visual of the difference between being somewhere comfortable and somewhere hooked up to machines. All right. So I mentioned I've been doing research on end-of-life decision-making. And you might ask, what do we know now? What do we know from the literature? We currently know that people often report experiencing distress related to death and end-of-life decision-making. This distress is felt by, well, everybody. Healthcare providers, loved ones of a person who is dying, and the dying person themselves can all feel distress. While we will be sad when someone dies, alleviating the distress would allow for better grieving and healing. Allow natural death is a term that was introduced by Reverend Chuck Myers in 2000, although he did actually start exploring the term in the 1990s. Reverend Myers was a hospital chaplain down in Texas who wanted to encourage better communication related to end-of-life decision-making. Unfortunately, he passed away a few years after introducing the term allow natural death. And it seemed like the attention to the term petered off a bit at that point. There has been, however, some empirical data through the years that has suggested utilizing the term A&D or allow natural death could be beneficial in end-of-life discussions. According to Stecker, the definition of allow natural death is that death will be allowed to occur naturally and interventions will be comforting and not life extending. Even though this term was suggested a while ago, the words we use during end-of-life decision-making continue to be of great importance and significance today. Currently in the United States, 43 states use what's called a POLST form. This stands for Physician Orders for Life-Sustaining Treatment. This is a form that people and their providers can sign after discussing end-of-life wishes. It can be kept in a prominent place in the home, for example, on your refrigerator, so it's easily found during an emergency situation. In 28 of the states that use POLST forms, the terminology of allow natural death is incorporated into that form. And only 4 states who use POLST forms use the terminology allow natural death only. Here in Washington State, allow natural death appears after a backslash after the words do not resuscitate. Do not resuscitate is the current terminology used when someone does not want to have life-sustaining treatments. Up until recently, allow natural death was in parentheses after the DNR. So this is a bit of progress. Another thing that we know is that in 2014, the Institute of Medicine, which is now the National Academy of Medicine, released a report titled Dying in America, Improving Quality and Honoring Individual Preferences Near End of Life. This report calls for increased communication between medical professionals and patients to ensure that people's preferences near end of life are honored. Ensuring that people die in a way they want is very much a focus in our country right now, which means that these discussions about how death can be better are very important. So currently, we don't really know how older adults, people ages 65 and older, understand the terms of allow natural death and do not resuscitate separately, or if they perceive any similarities or differences. So the purpose of my study was to explore perceptions of older adults regarding the meaning of allow natural death as compared to do not resuscitate, which, like I said, is the current industry standard. The hopes are that these insights will be helpful to patients, family, and healthcare providers when they are deciding what words to use during end-of-life discussions. When reviewing the literature, I was able to find 8 empirical studies focused on A&D and DNR, and there were also 12 studies that were focused solely on DNR. From these 20 studies, 4 themes were identified focusing on A&D, and 3 themes were identified focusing on the DNR literature. The first theme of the A&D literature is that allow natural death is found to be more acceptable than do not resuscitate to healthcare providers, surrogate decision makers, so those would be people making decisions for other people, for example, spouses or grown adults or grown adult children. And it was also found to be more acceptable among old, healthy adults. The second theme was that allow natural death was found to be a clearer way to communicate end-of-life decision-making to patients and families by healthcare providers. Third, all these studies used hypothetical situations for end-of-life decision-making. None of the studies actually utilized actual end-of-life experiences, and none of them allowed the meaning of the words rather, to be explored independently of a hypothetical situation. And finally, the allow natural death literature showed that there may be a relationship between context and meaning. When diving into the do not resuscitate literature, we know it's been around for a lot longer than allow natural death, which is part of the reason we got more empirical studies than we did when we were looking for allow natural death studies. There were 12 studies focused solely on DNR, and there were 3 themes that were found. First of all, the literature tells us that patients in healthy adult populations reported being familiar with do not resuscitate, yet demonstrated that they had different interpretations of what the words actually mean. Secondly, patient and healthy adult populations stated that they would have liked to discuss end-of-life decisions with their healthcare provider, yet we know that very few actually did in this research, or in the research, the DNR research. And finally, we find that providers generally understood the meaning of do not resuscitate. However, how they implemented those words varied. So the study that I did was a qualitative descriptive methodology. According to Sandalowski, qualitative descriptive methodology is a good approach to use when one wants to really portray the experience of the study participants. In this methodology, data are not overly manipulated, and the purpose of this is to keep the interpretations as data near as possible. For the data collection in this study, I was able to do one-on-one interviews that were conducted over Zoom because the timing of my study fell right smack in the middle of the pandemic. So I, for one, as much as we roll our eyes about Zoom, am amazingly grateful for this technology. So this study utilized qualitative, like I was saying, qualitative descriptive methodology, which is really a good approach to use when you want to portray the experience of the study participants. In this study, we focused on older adults, and the inclusion criteria were that participants were ages 65 and older, that they could communicate in English, that they reported not being diagnosed with a terminal illness, and that they could participate in the interview on Zoom. On each Zoom interview was the participant, me as the researcher, and I also had the pleasure of working with a research assistant who was a BSN student here at PLU. I really wanted to mention this student because she took field notes during each and every interview and was such a valuable part of the research, and I can't wait to watch where she goes in this nursing world. So here in Pierce County, Washington, we have a wonderful organization which is called MultiCare Celebrate Seniority. And MultiCare Celebrate Seniority and I collaborated together for recruitment efforts. Celebrate Seniority is a membership and volunteer program here in Pierce County, and they were willing to send out letters to their volunteers and members. Those letters, along with the snowball sampling, resulted in 24 participants. The participants in this study ranged from ages 65 to 89. Most of them were from around here, but some were from the East Coast. So now you're probably wondering, what did this data tell us? From the data I collected, 4 themes emerged. The 4 themes were control, emergency versus calm, communication is key, and quality of life. For each theme, I've chosen one quotation that I feel really represents the data overall. In theme 1, control, participants were loud and clear about the fact that they wanted a say in their end-of-life decisions, whether they wanted life-saving measures or not. The quotation here is from a person who we will call Charlene. She was a 65-year-old retired RN. She said, "It's not your story. It's the patient's story. It's my story, and I want to tell my story my way." She emphasized that death is not healthcare's story. It's not her family's story. It's her story. This sentiment was repeated over and over again. Eve, who was age 73, said that the terms allow natural death and do not resuscitate made her feel empowered. Emily, who was 70, shared her experience of a friend who died with cancer. She shared that it gave her a sense of peace, knowing that her friend had control in the end of his life. Abe, who was 67, shared that the 2 terms made him feel more prepared, and he likened it to being prepared for college or for having children. He said he wanted to be as prepared as possible for death. These findings are consistent with the recent research in advanced care planning, as well as the literature reviewed, when developing this study. People wanted to make their own decisions or want to make their own decisions in order to have control, as well as to prevent the burden of decision-making from falling on their loved ones. This control appears to be very important to older adults. This brings us to our second theme, which is emergency versus calm. This theme might be the one that surprised me the most. Overwhelmingly, participants identified that they thought the 2 terms, allow natural death and do not resuscitate, shared similar meanings, but that they should be used in separate settings. Marcus, age 77, said, but I see one as a situation that do not resuscitate is really, you've got an ambulance, you've got people there, and there's doctors and stuff, and you're saying, don't mess with me. The other one, it's, I'm at home, I'm going to die. Ione, who was 72, shared that do not resuscitate is used in emergent settings, using the phrase flurry of activity. She also used words like violent and not peaceful when speaking of do not resuscitate as a term. On the other hand, she envisioned A&D to be used in a peaceful setting, usually in the home. Bev, who was 78, stated, "Do not resuscitate has more of a kind of urgency to it." May, who was 73, said, "I mean, natural death. You see someone passing away. You say do not resuscitate, and you see them in a critical situation with people around them trying to decide whether to do something or not do something." Mervyn stated that DNR seemed more stressful and that A&D seemed more natural and relaxed. Overall, participants in this study felt that allow natural death was more peaceful and calm, whereas do not resuscitate seemed stressful and urgent. This brings us to our next theme, which is communication is key. Theme 3, communication is key. This signifies that communication is important at end of life. Ione stated, "End of life wishes should be communicated very forcefully, especially with older people, because in the moment, a son or a daughter, they're not going to want to let go. They're not going to want to let go. I think you have to make it very clear to them, this is what you want. This is your decision, not their decision." Many participants felt that it was the responsibility of the individual to discuss their wishes with loved ones and medical professionals. The general worry was that loved ones or healthcare providers would not follow through with the dying person's wishes unless those wishes were very clearly communicated. They worried that this would happen because their loved ones may be experiencing extreme grief when the time comes, or because they lacked understanding of the situation. It was also worried that healthcare providers may not be aware of the person's wishes, despite that documents may be on file in their preferred healthcare system. Kirk, who was age 74, shared a heartbreaking story of exactly this. He and his spouse had completed advance directives and had delivered them to their local hospital. When his spouse became ill, those papers were not front and center in the activity. And so the spouse ended up intubated and eventually passed away. Kirk assumed that the hospital would have that knowledge before intubating, but they didn't, and they ended up intubating his spouse. This is an example of what can happen if wishes are not repeatedly communicated. Many participants also discussed that communicating their wishes with loved ones was challenging. Some children or loved ones just do not want to think about a parent's death, so they are hesitant to be part of these conversations. Some people do not share their wishes with their children, possibly to shelter their children, according to Eve. All but one participant felt that discussion with family were of utmost importance in order to have desired end-of-life outcomes. That one person thought that end-of-life wishes were something only to be discussed with a doctor. She shared that they had never thought about discussing it with adult children and came to the realization during the interview that perhaps discussing their wishes with children would be a good idea. So this brings us to our fourth and final theme, quality of life. Study participants shared that the discussion of allow natural death and do not resuscitate brought the concept of quality of life to mind. Daphne, who was age 68, summed it up by saying, it's more of quality as opposed to life itself. As I said, my mother is 94 and I don't. And that's what's hard because I don't want to be her. I don't want to be the person who is kind of batty and sitting there in her diapers. Most participants in this study shared that for them, quality of life is being able to think, communicate, and maintain control over their life. For some, being able to connect with others was considered good quality of life. For one participant, Esther, who was 88, simply being able to breathe and take nutrition was what she considered good quality of life. It didn't seem to matter how quality of life was defined, but it was very connected to the train of thought participants shared when considering the terms allow natural death and do not resuscitate. The idea of quality of life is very personal. The idea that it is very personal is supported in the allow natural death literature. So now you might ask, so which terms do people prefer? In this study, people's responses really varied and no preference was identified, whether they preferred A&D or DNR was identified on the whole. Some participants felt that the meaning of the two terms were so similar that it wouldn't matter which one was used. Adele, who was age 71, stated, "Do not resuscitate speaks to my scientifically, medically inclined side, and allow natural death appeals to my woo-woo side." So, for me, it speaks to two sides of a personality, and they're both saying the same thing, just let me go. The participants who expressed a preference for do not resuscitate appreciated it because it had a commanding tone. For example, Kirk, who was age 74, said, I think that that request requires some degree of forcefulness. Do not, you're commanded, do not. And for those who preferred allow natural death, it was expressed that they found the term to have a calm, peaceful tone that not only put them at ease, but allowed for them to discuss and to have more understanding. As Daphne said, allow natural death. That's more of an allowance. It's more of a spreading of your arms as opposed to a do not. So what is this telling me? If you work in healthcare, you may want to use these terms and practice with them and see what works for you and your communication style with patients in different settings. For me, using the term allow natural death has always been beneficial in my nursing practice. As far as policy and education, we can continue to explore ways to make changes that will bring better understanding to the words that we use to decrease distress at end of life and in actual death. As I stand back and look at it, what I hear loud and clear from my study, as well as from the literature, is that we need to talk about death. Our society needs to acknowledge that we will all die, and how to do that in a way that brings peace and closure. Talk to your loved ones and to your friends about their wishes so that when the time comes, their people can advocate for them to die the way they want to. Will this make death easy? Nope, we're still going to grieve, but we will know that our loved ones died according to their story, and with that, there will be healing. Thank you so much for being here. I appreciate it.
Thank you so much, Dr. Erickson. Boy, so many things to stir on. Appreciate hearing all those different voices too that you brought to the table. Thank you. Just a reminder to continue to add your questions to the Q&A function. And now we will turn to our next panelist, Dr. Barbara Habermann. Dr. Barbara Habermann is the Dean of the School of Nursing and a professor at PLU. She is an established researcher in the areas of aging, neurologic chronic illness, and family caregiving. In addition to her extensive research, Dr. Habermann has served as an educator for over 25 years. Again, her whole bio is available on the event webpage. Today, Dr. Habermann will be talking about dyadic decision-making regarding end-of-life preferences. Welcome, Dr. Habermann.
Thank you, Jen. I also would like to start off by thanking the Lang Center for this wonderful opportunity and look forward to interacting with the participants today. I'm going to share my screen. Okay, so as was said, I'm going to talk about dyadic decision-making in advanced illness regarding end-of-life preferences. And by dyadic here, what I'm referring to is the family unit, i.e. the person with the illness and their closest family member. In much of my work, that has been their spouse or their partner. I've done much less work around adult children and their involvement. So by and large, this is either spousal or partner relationships that we'll be focusing on in the next 20 minutes or so. A little bit of background. My area of interest is and has been for probably several decades, is the notion of how people live and accept living with a chronic illness that is progressive in nature and is associated with the downhill trajectory. I think in our society, there's always a sense of tomorrow should be a better day. And so how do you manage having a chronic illness when that is not the case, when the days ahead are going to have a loss of function, a loss of many abilities? And this interest arose from clinical practice where I witnessed many who were experiencing chronic illnesses could find meaning and find significant meaning in their day-to-day experiences. But then there were others that could not. So that, as a clinician and beginning researcher, really made me question, well, why is it that some people can do this and other people cannot do this? This has led me on a research journey spanning several decades, studying people with Parkinson's disease and their family caregivers. And while there are multiple chronic illnesses I could study, and there have at times been brief periods where I've gotten into other chronic illnesses, Parkinson's disease has kind of been my passion. And I think part of it is that I think it's a paradigmatic illness in terms of it represents so well the type of my interest in terms of that it's not just a motor disorder. It's there are cognitive things associated with it. There are depressive symptoms associated with it. So it's a complex disease, and the management of it over time becomes more and more complex. I've been doing this work, as I said, for several decades, and I started sort of early in the disease trajectory, and then as I aged and things happened, I moved through the various levels of disease. And it's only in recent years, the last probably 7 years or so, that I focused on the advanced stages. And I think from a personal viewpoint, prior to making this shift, about 3 or 4 years prior to it, I had lost both my parents, and I think I needed time to grieve that. But then I also think that experience helped me appreciate how important it is to ensure that people have an end of life that looks like what they want it to look like. So over the last, as I said, about 7 years, I've sort of focused on people that we would classify as being advanced, and to really what persons in the dyads choose to how they want to live out the last months to couple years of their life. And it's really consistent with the notion is, how do people experience a death that they feel is good and that they have no regrets about how their life ended? So the first study, and I'm going to present on 2 studies today. The first one and then the second one builds on the findings from the first one. So as Dr. Erickson already alluded to, this was a descriptive qualitative study of couples or dyads with the idea of identifying their needs, concerns, and end-of-life preferences in the most advanced stages. And when I say advanced stages, it's without trying to make you a Parkinson's expert in a minute here. The simplest way I can explain it is these are people that are no longer mobile. They are totally dependent on assistive devices. They cannot walk at all, even 5 feet, without an assistive device. And this would include persons that are either chair-bound or home-bound. So 14 couples were interviewed on 2 occasions over a 1-month period. And the first interview was spent collecting data, collecting demographics, and then there was a separate, I went out to people's homes with my BSN student that I trained, and she was fortunate to be able to be on the project with me throughout the duration. So all interviews were either done by myself or my RA student. And one of us would interview the person with Parkinson's, and one would interview the spouse or the partner. And that was the first interview. Then we would go back, get everything transcribed, review for accuracy, and really try to use the second interview for 2 purposes. One, to clarify anything that came up in the separate interviews that was not clear, but also to interview them jointly in order to try to capture the dyad perspective as opposed to the individual perspective. So some of the major findings, and I'm just going to really kind of go through these fairly quickly. I'm not going to go into giving a lot of qualitative examples, or they will be very, very brief because it's a fair amount of content to get through. One of the areas, one of the needs that was identified was the issue of inadequate financial resources. As one person said, we have spent over $2,000 of our savings in the last 2 years alone. Another person said, we have spent $36,000 in prescriptions copays per year. That is not unusual. People with Parkinson's, have other health conditions too. But for their Parkinson's alone, they could be on 4 medications per day and multiple times per day. Another unmet area was respite care for the family member. As one spouse said, I just need a good night's sleep every now and then. And I think what's the important point of this little short quote is they're not asking for a good night's sleep every night. They're asking for, could I get a good night's sleep maybe once a week? Other major findings were related to what their concerns and what their preferences were for end of life. And by and large, the goal everyone had was to stay in the home as long as possible. The person with Parkinson's consistently identified that long-term care or long-term care placement was not an option. However, the family member, the spouse or the partner expressed that there might come a day where they could no longer keep the person at home as much as they wanted to. And usually that was related to some of the more significant symptoms that tend to occur when you're getting closer to end of life. Even though these people were chair-bound, falls still occur. And you may be thinking, well, how could a fall occur if you're not walking? There are major balance disorders. People can be sitting in a scooter wheelchair, stop it because they dropped something, lean over to pick up what they dropped, and just totally go over to the side and out of the chair. So issues around falls, and particularly issues around choking, which again presents in the very end stages, made spouses say there may come a time where I cannot do total care at home anymore. The other major finding or major need that people had was for better prognostic guidance from providers. People frequently spoke about, well, how can I make decisions if I don't know the time frame I should be making decisions about? If you can't tell me what things are going to be like in 3 months or what things are going to be like in 6 months and how things will have changed, I don't have anything tangible to base my decision based upon. So really a very strong need about needing to know what was coming next and what they should be expecting and anticipating. There were some serendipitous findings that I think, while not direct to the research questions, they were interesting findings. When I looked at, we did have about 4 couples in the study that had actually done some planning and looking at different options besides the home for living. And when I went back and examined it, all of the spouses in those cases had a healthcare background, and they were either social workers or nurses. And it seemed like if you had that kind of background, you were more likely, maybe less dependent upon what the healthcare provider was telling you, but you had a better sense of what possibly could be down the road. And they had already done some exploration of assisted living, long-term care, and or continuum of care communities. So communities where you could start off still in independent living, move to assisted living, and just keep progressing it as your situation warranted. While this data was collected, and as I said earlier, it was within a period of 1 month, so we're not talking a long time frame by any means, 3 of the dyads had to make living situation changes, and such as placing their family member in long-term care. And it was either due to a rapid deterioration in the person with Parkinson's, or that the family member had a major change in their health status, i.e. they were diagnosed with breast cancer and they were going to be having surgery and daily radiation, where they had to make this rapid change. And in all of the cases, it was very, very difficult because it just happened like very quickly. They had to do it. They knew they had to do it, but the person with the Parkinson's was just not prepared for what was going on, and was quite, in most cases, quite angry about the situation. So the major takeaway from this study is that families are not adequately prepared for what to expect what decisions they need to anticipate making. And really, healthcare providers need to better prepare them in this area. This study has been published, and I put the reference in there if you wanted to dig deeper into the results. The second study, which followed up, really built on the first study, was a mixed method study, again looking at dyads. And it was framed by an Ottawa decision-making support framework. And this is a framework that has been developed and been utilized probably since around 2010. And it really looks at what information and what types of information people need in order to make a decision. And then what are the outcomes of that decision, i.e., are they satisfied with that decision? Do they have a lot of conflict with that decision? Do they have a lot of regret about the decision? The framework is proposed to be a way that you could design interventions for families, i.e., for example, you could do an assessment of their needs. Then you could have a decision-making guide that they follow, kind of like an algorithm. If yes to this, go this way. If yes to this, but no to this, go this way. That wasn't the purpose of this study, but it is an exciting area for future work. So this was an exploratory sequential mixed method design involving joint in-depth qualitative interviews with the dyad. So it was both people involved. And at the end of the interviews, they were asked to identify a specific decision related to healthcare, either related to changing a provider or related to their living situation, with health being defined broadly. But they picked a decision that they had made, preferably in the last month to 6 weeks, so that it was relatively fresh in their minds. And that was identified together, agreed on together. And then they each filled out quantitative measures, which I'll describe a bit more in a minute, independently about their satisfaction, et cetera, with the decision. We collected data at time 1 and time 2, and the time span of this was 6 months apart. The rationale, and we'll revisit this rationale in a minute, but the rationale was that in advanced stages of Parkinson's disease, usually there is significant progression within a 6-month period. So we felt like we would capture some changes during the period of time. We had 15 dyads or 15 couples, total sample of 30. The quantitative measures we used, and these are all well-established measures with good Chromax alphas on them. The decision self-efficacy scale, which measures the belief in one's ability to make decisions. And it has items such as, if I have the right information, I feel comfortable making a decision, and you rate that, how you feel about that. Decisional conflict scale, which measures uncertainty and satisfaction with the decision. And then the decisional regret scale, which measures distress or remorse about decisions. So the qualitative findings first, and then I'll go into the quantitative findings. The qualitative findings, very briefly, which were common across both time frames, i.e. time 1 and time 2, fell into 4 categories or 4 themes. The need to obtain more help and services in the home. By and large, at both data collection points, everyone was using some sort of additional help in the home. What that help maybe was just coming in once a week to help with showering, on up to then potentially having somebody come in 1 to 2 nights a week so that the family member could get a good night's sleep. So we needed more help and services in the home. And most of those were paid out of pocket, I might add. Moving into assisted living communities was a common thing. We had a number of people between time 1 and time 2 either make that change, or at time 2 were in the very planning processes of making that change. And I think what was interesting was a lot of the couples potentially had moved somewhere, and maybe 8-10 years before, as the place that they were going to retire to, or where they wanted to spend the duration of their lives. And what was happening was many were having to move back closer to where they had adult children and the family support because they needed more help. number of people or dyads in this sort of maintaining as is as long as we can. And so these were people that weren't really making decisions to do any different. They were like, we're going to hold on, live in our house as long as we can. And for some people, this meant that they were living in a very limited area of the house, that they had long not even been up to their second story, and even were to the point that they were maybe living in 1 or 2 rooms. And we did have some people over the 6-month period actually decide to go ahead and initiate hospice if they really were getting closer and closer to those end days. So when we looked at the various measures, those 3 scales that I briefly mentioned, we found no significant differences between the person with Parkinson's and their partner on any of the 3 measures. The decisional self-efficacy scores were high, so that means that people were confident that they had the information they needed to make a decision. That the decisional regret and conflict scores were low, and they were really quite low compared to other published reports in the literature, which, when comparing to other chronic illnesses. So some limitations of the study, and I think these speak a little bit to why we didn't find any statistical significant findings. Now, some of you are probably saying, well, it was a small sample, but it met the assumptions of the statistical tests we used. It was a highly educated sample. This is not unique to my studies. Most of the studies with Parkinson's people and their family members, they are a highly educated group, which can raise a lot of different questions as to why we see that, but they were very highly educated. So that may explain why they felt, compared to a general population or other chronic illnesses, why they felt like their self-efficacy, their ability to make decisions was good because of their background. It was not a very diverse sample in terms of not only educational level, but there were only a couple of underrepresented groups. There were 2 African-American dyads, and otherwise it was a Caucasian sample. Again, when you look at the Parkinson's literature, that's consistent. So again, raises some questions. And probably one of the more really strong contributing factors was most of these dyad relationships were long established. Most of these were coupled or partnered people who had been in relationships. While they may have not been married for 40 years, they were in the relationship for mean of 40 years. And then it raised the question as to whether or not a 6-month time frame when you're exploring decision-making in chronic illness is an adequate time frame. When this study was designed, there was nothing in the literature at all to help make that decision. It was more of a sense of myself and my co-investigators who are experts with this chronic illness, our best determination, kind of testing the waters. Since we conducted the study of PCORI, which, if you're not familiar with PCORI, it's Patient-Centered Outcome Research Institute, which is a fairly big funder these days of research, clinical research, has come out with the recommendation that people be followed for at least 1 full year. So that would be something to consider for future studies. So in conclusion, changes are needed in our healthcare system to allow providers to have adequate time to impart prognostic information. I'll give a quick example on this. Most people with Parkinson's see not only see a neurologist, but they see a movement disorder specialist. So somebody who specializes in movement. And in conversation with a movement disorder specialist that I've known for probably 20 plus years, she said to me, having those conversations with families is difficult because she said, it's not a billable service. And so you don't really have the time that you would want to have the time to spend with the families to help them. But it creates this tension that the patient and the family members are saying, I need more prognostic information so that I can be informed, so I know what decisions to make. And they're just not getting that from their health providers. And I think the other part that's important with this is, this isn't a one-time conversation. This is a conversation that needs to occur multiple times So that's an area that we're not doing a good job in our healthcare system. Families need more support to identify the nature and anticipated timing of decisions. And they need to be engaged in the discourses and dialogues on a regular basis. And I think more often than not that much of the discussion of decision-making and end-of-life preferences is probably sometimes not best delivered by a physician. And that there are many people, many disciplines beyond medicine that probably need to be involved. And I know sometimes in talking with my nurse colleagues, particularly that are more end-of-life focused, they're like, well, I don't think I should initiate the first conversation. I think that should come from the physician. I think it's most important that the conversations occur. And if that's because of the nurse starting it or just asking the family, what are your concerns? What are things you feel like you need more information about as you plan towards the future? It certainly is in the scope of practice for advanced practice registered nurses. And I believe it's also can be part of the practice of social workers and family marriage therapists, to name just a few other disciplines. So that's the end of my discussion.
Thank you so much, Dr. Habermann. Wow, there is a lot to consider in all that affects folks trying to make these decisions, from finances to understanding of the disease, what other support they have, and appreciate your conversation about the role of healthcare providers in this. And I love that you also mentioned that your research was conducted with a BSN student. So that's great that our students are having the opportunity to be a part of these studies. Thank you so much.
Thank you.
All right, continue to add your questions to the Q&A as we welcome our final panelist, Dr. Mark Mulder, Dean of the School of Business and Associate Professor. Dr. Mulder is an active researcher in the area of transformative consumer research, including research reimagining in the end-of-life journey to help it be even more fulfilling and impactful. In addition to his research interests, Dr. Mulder's personal experience with family members who have passed has inspired him to help alleviate the stigma around end-of-life journeys that focus as much on the life part of the journey as the eventual passing. Again, you can read Dr. Mulder's full bio on the event webpage. Dr. Mulder's talk today will be about reimagining the end-of-life process, healing before passing. Welcome, Dr. Mulder.
Thank you, Pastor Jen. Great to be here with you all. Thank you all for participating in this session, and thanks to all of our Wong Center colleagues for all the great work, and for you to be here on a Thursday afternoon listening to the topic of end of life and death. Kudos to everybody who's watching and participating in our session today. I am going to be talking about end of life, not just from a medical perspective, but from a marketing perspective. And like our colleagues, Dr. Erickson and Dr. Habermann, I too have a personal journey in this, as Pastor Jen highlighted, and that's what informs a lot of my interest in my research. Pastor Jen mentioned that I do research in the area of transformative consumer research, and in this particular area, we try to take societal challenges that haven't been studied as deeply as they could, and where marketing and business research could come alongside of other disciplines for an interdisciplinary approach. And thus, we are going to be talking today about healing before death and how there's a lot more opportunity for us as a society. So why do I care? Well, I have had the journey of saying goodbye to 4 parents in 4 years. The last 2 of them happened within a span of 47 days. And so I've lived this not only as a son, not only as a family member, not only as a researcher, but as somebody who observes and tries to ask broad questions. And so my academic research questions, as I reflected on that journey, was front and center. And so that's what informs some of my questions. We look at exploring the triad of the patient, of the family, and of the caregiver, and really are focusing on how to normalize the end-of-life conversations. You're going to see threads from Dr. Erickson and Dr. Habermann in my presentation, although it is going to come at it from a little bit of a different angle. Some insights about our research, and when I say our, there are a variety of other researchers that are involved in this. And some of the research that I'll talk about today is actually going to be presented this summer at the American Marketing Association Marketing and Public Policy Conference. And so this is research that we've conducted that we're excited to share, and baseline research to broaden these types of questions. I think one of our findings is we really stink at this process, and I'm going to explain a little bit about why. And that framing is everything, as our other panelists have mentioned. So I'm going to talk first about the papers. I'm going to put papers in quotation marks because, as you've just heard, there are a lot of things that we have to think about in the end-of-life process as a patient, as a family, and as a caregiver. And a lot of these come out in the area of wills or power of attorney or a healthcare directive or a health proxy or some type of a trust to organize our end-of-life journey, particularly towards the very end. And so we wanted to explore a baseline. What does it look like? How many individuals in the United States have completed these documents? So we did a representative sample of about 320 US citizens from 48 out of 52 states that were designed to be a representative panel, given their ages, their backgrounds, education levels, et cetera. And when we asked them, we were surprised in a good way to find that 7 out of 10 respondents indicated that they had actually completed one of these documents. But when we looked at the actual number of how many had completed each type, we found that in many cases, 8 or 9 out of 10 Americans had not completed these particular documents as an individual document. Some had done one, but there was still a lot to do. And what we wanted to understand was the baseline of what are citizens doing and how are they preparing? And the short answer is we're not very well prepared. There is a ton of research in so many different disciplines that talk about incremental components, yet the part that we want to explore is, as a society, how can we do better, not only in these documents, but some other areas beyond the documents that I'll talk about today as well. So some complete these forms, but there's a huge opportunity that remains. And so how do we move to wider adoption? Well, we looked at some of the predictors, and perhaps not surprisingly, those that had completed documents, completed one or multiple, there were some predictors. Education, higher levels of education predicted higher levels of completion. Income, higher levels of income were connected with higher levels of document completion. And then knowledge. We heard about this in some of the other presentations. The efficacy and the self-confidence or self-determination components were related to completing these documents. And so, well, what do we do for society that isn't high income, that doesn't have a lot of knowledge in this area, or may not have advanced degrees? And that's the question we want to better understand. And one of the questions we wanted to understand is, why did people who had completed their forms, why did they do it? And many of them suggested that they had turned 50 or 60 or 65, and that was the driver. A particular year of a particular birthday, and the higher the age, the more likely they were to have completed this. Some had a significant life event. It was a component of having children or having been married. And at the time of marriage or the time of having children, thinking about a will or thinking about some of these other documents were a piece of it, but certainly not always thinking about the end of life when some of those documents were completed. Some had a recent experience with a family member or friend. Some actually did this as a group, which is fascinating. A group of people got together and said, let's do this. And others were incentivized through their work to actually have these documents done. So some indicators of how we might start thinking about this and how we might actually connect to encourage this. So what we're trying to do is to think about how we normalize these conversations in planning. As our other panelists had highlighted, we don't like to think about death and marketing, and in other areas, we call this mortality salience. Thinking about death creates anxiety, and we don't like anxiety in our life. And when we have this type of anxiety, we try to avoid it. And in many cases, the way to avoid it is avoid doing the process. And not everybody understands that the way to avoid anxiety might actually be completing these, because then there is less unknown, and unknown areas can create anxiety as well. So we want to take a look at how do we move this back? How do we move this earlier in life? And what are some on-ramps that we can consider as society and as researchers to have these conversations? How do we normalize this and break the stigma around talking about death. We don't like talking about our own death. We don't like talking about the death of our loved ones. And that's kind of the component of a stigma, right? It's something we don't necessarily want to talk about, or we're uncomfortable talking about it. And yet we need to have these conversations. And so I'm going to talk a little bit about some insights and insights of my own particular journey. And what I wanted you to do in this next slide is I want to celebrate the role of mom. Think about a mom in your life. It could be a mother figure. It could be a birth mother. It could be a family mother. There's a variety of ways that we can think of this role in our life. But I want you to take a moment and just think of this role. And I want to share with you some of my own thoughts and some of my own experiences. I remember when I was relatively young, I looked in the mirror and I thought something was really wrong with my tongue. And I asked my mom, I think something's wrong. And she sheepishly shared with me a story that when I was young, I had a walker. I had an opportunity to zoom around the house in a four-wheeled walker before I could actually walk. I was cutting my teeth. I had a couple of teeth in, and my mother actually went down some stairs, closed the door, but not all the way. And being the inquisitive child I was, I decided I was going to learn how to open that door, and I was going to go see mom. The challenge was walkers tip. And when my walker tipped, my chin smashed against the floor of the stair, and my tooth actually went partway through my tongue. My mother, who was heard the noise and commotion and the screams, couldn't figure out what had actually happened. And she very sheepishly shared that there was blood everywhere, and she didn't know how serious this was. And this was one of the first times I remember my mom crying about something that had happened when I was a child. She teared up, and she was recounting the fear and the horror and the guilt that had gone through that. It was just something simple, and it was my fault, not necessarily hers. But there was a ton of love that came through that story. And so that component of love, that unconditional love that comes from family members, is beautiful, isn't it? What I want you to do is think about something that you might have had growing up. Maybe it was a dish that you had a ton as a child, and perhaps you may not love eating that dish anymore. My memory was tuna noodle casserole. And yes, it even had the crunchy potato chips on top. I know that I ate that way too often for my liking when I was a child. In fact, I can't actually still eat it now. It's not terrible. It's just one of those things where I've had enough in life, and there's so many other good foods I can try. But the reason that we had it too often, I would say in quotations, was that my mother was working 2 jobs, and feeding a growing family was tough. She could flash cook the egg noodles. She could add some tuna, some cream and mushroom soup, cook it in the microwave, and throw some potato chips on top for some crunch, and done. Dinner was done. It was made out of both necessity and love. Next, I want you to think about a time where you got busted. You were trying to pull a fast one on mom, and you got busted. My case was between the summer of my 3rd and 4th grade years. Our family had moved to a new town, and the idea of a new school was daunting to me. In fact, it was downright terrifying. I was stressed, and I was feeling sick to my stomach as the school year hit, and then my inspiration hit. I simply had to say that I was sick. My stomach hurt really bad. And that kept me out for day 1 of returning or coming to a brand new school. I must not have been that convincing as an actor, because mom said, all right, tomorrow you are going to school no matter what. And so I needed a new plan. Stomachache was out. How about a fever? Yes, a fever. So I got the thermometer. I told my mom I had a fever. She felt my forehead, and I think just to call my bluff, she actually gave me the thermometer. And now what? I got a thermometer. It's not going to show that I have a fever. What do I do? I could put it in the microwave. Some of you are cringing right now. Thankfully, I didn't. I could try to run under hot water, but that would make a lot of noise. And then my inspiration hit. Sitting next to me was my mom's cup of coffee. Boom. I put the thermometer in. I heard footsteps coming down the hall, so I put it back under my tongue and showed my mom. And she said, wow, you have a fever. Yes, I said, yes. And then she said, you should be dead. 107 degrees is fatal. How are you alive? A miracle? I asked sheepishly. My mom looked at me, looked at the coffee, and then smiled. In the car, bud. I'm walking with you to your new classroom. Next, think about a time where a mom showed love, sometimes without even saying anything. For me, that was the story of a pink blanket. We would be in our home, laying on the couch, resting or reading or doing something, and out would come my mom with a pink blanket that had been in the dryer for about 10 minutes. She would go put it in the dryer. It was a down blanket. She would just put it over us, kind of tuck us in a little bit. The blanket was warm. She didn't even have to say anything. She would just smile. She would walk away. And that was a component of love. You probably have memories that are similar. The last thing I'll highlight is care and the importance of teaching, care personified. My mom was a nurse, and helping a doctor help families was important to her. During a recession, there were a lot of families that had lost their job and thus their insurance. And while their insurance lapsed, the doctor decided that their care would not. And even if they didn't have insurance, the doctor would still see them. They would actually see them after hours, so they didn't have to be something that was a cost to the clinic, and they would have families. So despite insurance lapsing, relationships continued. And she would use her own time to be able to help make sure that people were still healthy, even though they didn't have insurance and they had nowhere else to turn at the time. So thinking about moms, thinking about family, thinking about a history of some type of a relationship. And I realize that not all of us have the same experience, not all of us have the same background when it comes to that mother figure. But I want you to have that context, because what I want to do is fast forward to March of 2013. I went to a care center where I was called because my mother had had a variety of crises. She had been diagnosed with MS and dementia. And she was in a crisis mode as the dementia was continuing. She had been with my father, and they were camping. They were living on the road, and the camper or motorhome was a safe place for her. But the disease progressed, and he quickly became outmatched in his ability to provide care and needed some support. So fast forward about a month, that's when I saw my mother for the first time. She looked at me, but kind of looked through me. She didn't really know my name. She really didn't communicate. It was a combination of the advanced progression of her disease as well as some medication. I was pretty sure she didn't know that I was Mark or that I was her son. And that was tough. That was really tough. I was bitter. I was angry. I was in shock. This was a shell of a person that I knew. And it took a long time for me to really work through that. And so I would say it probably took 3 to 4 months for me to have this lesson. My lesson was that I was focusing on what was lost. I missed what was left, and I could have missed the power of love. Now, I didn't miss what was left forever. It just took a while to get there. But that by focusing on what was lost, I was not honoring what I could do as a researcher and as a son. And I wasn't the opportunity to move forward in love. So we did this actually as a family. This is my mother at that care center later. She was not communicative. She would say a few words here and there. She would say some sentences that didn't make sense to us, maybe had made sense to her. And here she is at a barnyard day at the care center where she has a little bunny on her lap. And so this became a family affair where my son and my daughter would go to visit. This is my son holding his grandma's hand as they're taking a walk. My daughter would, and we would take turns. My mother, because of her MS, couldn't feed herself. And so family stepped in, including my father, who pretty much had lunch and dinner with her every day. And then we continued that family time. Indoors, outdoors, sunshine, cold. We had a chance to let love lead, and we focused on what was left and the opportunity for us to really care and to really show. The reason I show that is, this journey is tough. We know that. And for all purposes, my mom was perfect case. She had all of her documents in hand. She had all the documents, a will, a power of attorney, a post form, a healthcare directive. We knew exactly what she wanted medically and what she didn't want. But there was still something that was missing. There There was still something that was missing in this journey, despite that paperwork being present. So I want to talk a little bit about the role of now and how some surprises are not fun. We always thought that my mother, given her condition, at some point would pass, and my father, who was healthy, would figure out what life looked like without his spouse. Unfortunately, life had different plans. My father was a veteran. He was drafted. His country said, "You need to go to war," and he did. And while he was drafted, or while he was serving, he was exposed to Agent Orange. And this was back when the military would give out cigarettes in MREs. Not surprisingly, later in life, because of that exposure to Agent Orange, he developed lung cancer. And it was a pretty quick journey. And so this is actually a photo of him with my wife, and they are sharing photos of some hikes, and you can see the joy in their faces. The journey was tough. It wasn't always joyful. And there were some things that had kind of emerged. And I also had some lessons that the light that is here is really in the how, but that there's something actually more. And one of the things that came out of this was the emergence of the persona. In marketing, we'll often use a persona to think about a journey, to think about some type of a relationship or an experience. So if we worked, for example, for REI, and we were going to make a persona of a typical REI customer, we might think of someone who cares about the environment, who cares about the cooperative model of democratic member control, where I'm not just a customer, I'm a member, and I have a say in an organization. The continued theme of working with students and researchers, Sarah Cornell Meyer and I had a chance to be paired in a Benson Fellowship, and we did some research looking at the communication style and what emerges when someone is diagnosed with a terminal illness. And what we found was that there were three personas that emerged in our research. We looked at family members and friends of those who had a terminal illness, as well as caregivers. The first one was being a fighter, and this was, I'm going to get the boxing gloves ready. I'm going to beat this disease. I'm going to kick cancer's ass. Whatever the terminology is, I'm going to be the Rocky Balboa of this disease, and I'm going to beat it. Another persona that emerged was a caregiver, really taking on the cloak of caring for others and trying to figure out how not to be a burden in many cases. And some were deniers and avoiders. They just didn't want to talk about it. It was not comfortable, and they did not want to talk about it with family. In some cases, I saw many of these through my father and his own journey, and the opportunity to see this after the fact and look back and to see how it emerged in his conversation, and to see the vulnerability that's tough for it to come out, but beautiful when it does. And so what I want to think about is what happens when these journeys come together? What happens if we don't necessarily have a script or a narrative? We have the forms, but we don't have a script or the narrative. I didn't have something for my mother that said, here's exactly what I want my end of life to look like. I didn't have something for my father. Even though we spent great time, we really didn't get a chance to map out what a great end of life would look like. And what we find is that many people would say the same thing. And so this is actually a photo. My father, as he was getting close to passing, his hospice worker said, you know what? I think he's holding on. And I think he's holding on for your mom. He wants to know that she's going to be taken care of. And so this is actually a photo of her kissing his hand as she was saying goodbye and allowing him to transition. So my lesson is that there can be healing. This was a powerful healing moment for us, even before and amidst death. And it could be beautiful. So how do we harness the beauty of this? If my parents had written a script, it would probably have looked like this. 50 years after these photos were taken, this is where they were. This is my mom as she was graduating from nursing school, right before my dad was shipped off for his being drafted. My dad did not identify as someone strongly as a military veteran. He appreciated his service. He loved his country. But this was him as he was getting his orders, and they got married right before that transition happened. And as he went off to war. So there's some open questions. Where are we heading and what does this research have? We know that there's an opportunity to do more for society, of really how to prepare for the end of life. We know there's a growing body of research, yet we are woefully underprepared for what's coming and how to really do well at end of life. What if we could become better at the paperwork part of planning? That's the theme in all three of our presentations. But even more important than that paperwork, how could our own journey of mapping what a good end of life would look like? What if we transitioned the light not on the death, but on the time before the end of life? And so what if we could reimagine this by thinking about dying well? And not only the process of dying, but thinking about it earlier in life so that we can think about what we want that journey to look like and to be able to really write our own story. There's an organization called Death Over Dinner. I've had a chance to work with the author. It's been completed by well over 1 million people in the United States. And so this idea of talking about death and thinking about what we would want or not want as we think about our end of life, not just our death. And so whether it's Death Over Dinner or a space at Round Glass, which I will highlight here, here are some resources that are fantastic. And actually all three of these are partners in our research as we're think about the norm and how do we normalize these conversations. I think the role of us as a director or an author highlights that there's poetry in everything. That photo that I showed you of my parents saying goodbye was poetic. It was heart-wrenching, but it was beautiful, right? And so how do we think of bringing that beauty earlier? How do we think of a good end of life, not just a good time after a diagnosis? And how do we write and journal and think about this at different points in our life? And how do we allow that journey to become really our own, not scripted, but defined as to what we want and what we don't want, and how beautiful it would be if us as family members had a document like this, not only the documents and the forms, but a document to say, here's what I want my end of life to look like. So in the best of cases, I think the beauty is that we can have healing amidst dying. We can have healing before death, which is kind of the oxymoron from the medical term, because death is usually when the healing isn't possible and when the illness takes over. I'd love for us to harness and to help make this happen. And so if you have thoughts or ideas, I'd love to be in touch. And with that, I'll invite Pastor Ruud back. And I want to thank you for your participation today.
Thank you, Dr. Mulder. Really appreciate you inviting us into the story of your parents, the love story and the healing story for your whole family. You all have shared really personal encounters and really helped us remind us maybe that it's not just an intellectual conversation, but it's about our stories and our relationships. So thank you. I do have a few questions ready for you all. And again, folks who are watching, you're welcome to add to the Q&A function. But we'll begin with this person who wrote a question says, I have been in nursing for 33 years with 25 years as an adult NP working in nephrology, vascular surgery, internal medicine, and most recently in occupational medicine. My experience working with, and they name a variety of medical professional colleagues, I have found it interesting that many providers have difficulty discussing end-of-life options with patients, particularly in patients with chronic conditions. How do we implement change to help providers become more comfortable in talking about death, helping their patients plan for death?
I can start, and then others, please chime in if you care to. Your observations are extremely consistent with my observations, and I think the only time that I've seen where those conversations start at appropriate timing usually is in the case of something like cancer, when the prognostic indicators are pretty clear. That the cancer team will say, we're 6 months out, 8 months maximum, that type of thing. And I think it is the chronic illnesses that have so different trajectories where you think sometimes, oh, this must be, we're getting to the final months of life. And then somehow the person bounces back and does another round. And I think that's what makes it challenging for people as to when to initiate those conversations. But I would emphasize the point that it doesn't take a medical degree to initiate that conversation. And I think patients and their family members are just really hungry for that. And so, sometimes it's practicing. There's a particular game you could do that I actually did early on, because it was like, well, what are my end of life preferences? What does that look like for me? And what I found it was that I was a control freak to the max. I wanted control over everything. But I think not, everybody's different. So I think the only way we're going to really be, as healthcare providers, at all effective is to just initiate the conversation. And with time, you get more and more comfortable.
I appreciate you naming that you're a control freak and thinking about your end of life. And I was sort of curious, what kinds of conversations do you as individuals want to be having or are having with your loved ones regarding end of life? Kind of how has your research affected your personal reflections and your family conversation? One of you used the term mapping a good end of life. Just wondering kind of how your research is impacting your individual lives and that of your families.
So I can speak to that and a little bit to the question before as well. I think one of the things that we can do with our research and is use what we find to empower people to have conversations about death. Because when you look at society, back in the 20s, 100 years ago, people died at home. We didn't have these medical miracles that would keep us around forever and ever. And death was an accepted part of life. And then as we've progressed through history, we've gotten to this point where as society, we just don't address end of life decision-making at all, or it becomes very fearful. So I think one way we can help providers become more comfortable is by empowering people to talk about it with their loved ones and to bring it up to their medical providers. For me, on the personal level, I think it's something that my family has become more comfortable discussing. If you could see my bookshelf over there, it's full of books about end of life. And so it's kind of become normal. Even my 18-year-old had to do a research project in their AP research class, and chose to do it on end of life and the perception of young adults on end of life. So I think empowering people that way can be really helpful. Also personally, you'd think it's something that we talk about all the time and that we'd have all of our papers in a row and all those conversations had. Personally, when my mom became ill, luckily, she had sat my brother and I down and said, don't intubate us. Don't intubate me, nothing heroic. When she did end up getting sick, it was very quick, but there right at the end. And we did allow for her to be intubated because we needed to see if medicine could, take care of it and we could get her back to baseline. Ended up extubating her, but she could never kind of get on her own 2 feet. So when it really came down to it, we were able to say, Mom doesn't want to be kept this way. And we were able to keep her comfortable thanks to the nurses and everything. But it was something that I don't know if because it had been something we talked about, but Mom had those guts and sat down with us and said, look at Jodi and Eric, this is what I don't want. So when the time came, we were able to help her die peacefully and comfortably. And that, I think, for me, has provided a lot of healing over time. So
I would just add, moving it earlier as far as conversations, going back to the first question, then I'll tie it into the second, but moving it earlier, if let's assume that death as an analogy is the ultimate graduation from life. Are there other things around graduations from a master's degree or other degrees that could be components where we say, okay, instead of me being 70, I'm going to do this when I'm 40. I'm going to do this when I'm 30, and I'm going to kind of chart my course. We know that people are actually motivated by fear. And unfortunately, fear is a powerful motivator. So maybe it's, how do you not want to die? What do you want to not have as part of your journey or story? If you can if you have the ability to avoid it. And then go to the beautiful side, right? If you could script and write your own end of life journey, or the last 5 years of your life, maybe we talk about it, as kind of the final decade or the last 5 years. What do you want that to look like? And that could be a really powerful story. And if we can think about that earlier, because we don't know when it's coming, then we're prepared. And think about the beauty of us being prepared, as well as our family, knowing what it is that we want, more than just a variety of forms. Those are incredibly important. But what if the narrative was something that we shared and that we created with family, and we were able to talk about it with our loved ones? I think that could be powerful. And I think the opportunity, my opportunity isn't with my parents anymore, it's with my children. And so my own question is, how and when do I do this? I've actually started a document that's putting down these thoughts, and I don't know when it's going to be shared, but I've actually started mapping and writing what are the things that are important to me, either to avoid or to move towards. And that's actually a healing process. It's not always easy, but once you embrace it, then it becomes a part where you're envisioning your future, and that actually is more powerful than avoiding it.
Thank you all. I know from my own parents, as they kind of encountered end of life with their parents, it opened up conversations for us between me and my parents, and how they wanted to go. And this is kind of connected to this question here. As I hear about your journey towards research on death and dying, I'm struck by how in all three of your cases, it was triggered by proximity of death in your family or among loved ones. Another thread in your talks is the general reluctance to think about or talk about death, even if it can be healing to do so. So they have two questions. You've sort of begun to answer this. In a perfect world, how do you see a way forward to becoming more welcoming of the dying process? And then the other question is also a comment. Not all cultures are as resistant to death and dying as we are in the US and in the West generally. Are there other cultures and communities in the world that may show us some pathways?
I'll make a comment on the last part. I think it's very true. It's the Western world that seems to really struggle with this quite a bit. That being said, I'm involved with a project that actually we're trying to get some grant money to get the project really going, but it would be a collaboration with gerontology people in Japan to look at this whole sort of aging in place, staying at home, dying at home. And I think as a culture that they do a much better job than we do with this. So I'm hoping to learn more about that. There might be some practices that we could draw upon.
I'll just go ahead, Jodi. Sorry.
Oh, you can go ahead.
I was just going to talk a little bit about the second part of the question in culture, and certainly certain communities in Mexico or Peru or other communities that are indigenous in nature really believe we're born from the earth and we return to the earth, and that's part of the natural cycle, and it's to be celebrated. And if you've ever watched the movie Coco, you can see where the idea of living with loved ones who have passed and talking with them is actually a part of the story and a part of the journey. There's actually some research that suggests that the whole stages of grief, there could be a different way to look at it. And this idea of moving on instead of living with, and some research has kind of pointed to the idea of having conversations with loved ones. Hey, Mom, I'm thinking of you today. I love you, even though it's somebody who has passed. And this idea of just kind of walking with. And culturally, in some cultures, that's one of the ways that it's there. It's that memory that's alive, and we honor the memory through conversation rather than just kind of putting it off to the side. So I think we have a lot of opportunities to see how death is handled in other countries, and whether or not that works its way in to perspectives for us. And for the Western US or the Western part of the world, that might be some really cool opportunities in research.
I just wanted to mention also, I think that we can, as Westerners, learn a lot from different cultures. One of the participants in my research study that I did for my dissertation, she really had done a lot of studying about the Buddhist culture, and that had brought her a lot of peace and calm when she was considering her own end of life wishes, which I thought was really neat. I think too that there's some research out there. The name that comes to mind is David Kessler, who worked on Elizabeth Kubler-Ross's the stages of grieving, and he identified an additional stage which would be that of making meaning of end of life. And I think that that's a really powerful tool also that we can give to people before they pass away or to their families afterwards. How do we make meaning from someone's life and their death, and what does this mean? I also love, Dr. Mulder, that you just said to talk to someone after they're gone. Like, that personally brings a lot of peace to me. And so I feel like if we could kind of take all these things and put it together and make them well known, we can really make an impact.
Thank you. That sort of segues into kind of what you started talking about this, Jodi, but what tools from religious or spiritual traditions have you maybe explored as part of your research and experience connected to end of life?
That was one of the things in my study that came up quite a bit, was the idea of faith, and people had different faiths, and they would speak to that quite a bit as to how their faith informed their beliefs on end of life. And that's honestly something that I would like to look into further. I know as a nurse educator, we talk to the nursing students a lot about how do you understand your own or how do you perceive your own understanding of death, and how does that impact your practice when you're working with others? And how do you, as a nurse, take the time to really ask the questions of our patients and our clients so that we can understand their perspective and where they're coming from with regards to religion? And how do you help ensure that that knowledge lets you as a nursing professional be the best nurse you can be, and make sure that that person has the end of life that is congruent with their beliefs? I think that's a really interesting topic. So thanks for asking that question.
We didn't look at faith specifically, but we always ask about it. And it never ceases to amaze me how broad different backgrounds are for those who participate in research and what they bring, whether it's agnostic or a particular background or faith background. And so I think one of the things that I saw in a healthcare specialist, I think with a hospice worker who sat down with us and a loved one, who asked the question, what matters most? Like how does this person define themselves and what matters most? And, there were some questions about faith and some other things. And then that was documented, and it was that language that was used in future interactions. So that was the foundation of future conversations. And I thought that was absolutely beautiful. And as a marketer, in marketing, we will often ask, who's our audience? What do they care most about? Because we want to focus on them and the opportunity for that connection to be true and authentic, and to use language that's important. And I love that that's what happened in that healthcare facility, in that healthcare setting, around faith. What does this person have a faith? If so, what's important to them? What are their, what do they think will happen after death? What do they think will happen during death, based on faith? And not assuming that one particular faith has exactly the same journey, but really just inquiring and figuring out how that could be customized. So it was powerful, and it was beautiful to see.
Thank you for that. It makes me think of, really, there's a team of healthcare providers. My spouse and I, when we watch medical shows, we're always like, where's the chaplain? Why don't they have chaplains on this? Because our chaplains in healthcare setting are some of the most interfaith competent folks, because precisely that, like, we can't assume that someone's path will be similar, depending on their spiritual or religious practice. That ties in with another question. I think it's probably from a healthcare provider. It says, how should our own beliefs, personal, cultural, religious, impact how we talk to patients about end of life?
I guess my initial response would be that our own beliefs, on some level, can't be first in front. That we have to be able to, while each of us might have a real good sense of what we believe would be good death for us, we can't make assumptions that that's a shared value or belief. It really, I think, has to be started in a much open-minded place in terms of what would this look like for you? What do you care most about? Type of thing. I think I've worked with students that are very passionate sometimes about end-of-life care, and they try to say things like, well, don't you think you should? And it's like, no, remove that from your vocabulary. Ask what they want and start there.
All right, let's see here. We've begun to answer this, but my assumption is that stigma and anxiety around end of life has shifted over the generations, and as we mentioned, varies by culture, religious or spiritual tradition, other identities. I wonder if y'all just might have some thoughts about why do we have the stigma and anxiety in this, we talked about maybe a current US Western culture. Like, where does that come from? And maybe in recognizing some of those barriers, we could have a sense of how we begin to transcend and even heal from those. And maybe even by time period. I don't know if that's a thing too. Jodi, you mentioned, when people died at home more. So that was a piece of it. But just wondering if you have any thoughts on that.
I don't know as much about how it's changed in the area of anxiety and end of life concerns, frustrations, avoidance. But I'll tell you what gives me hope. And what gives me hope is the conversation around mental health. For many generations, mental health was the similar type of stigma. And we didn't want to talk about it. We didn't want to admit it. It was a component of often shame in families to talk about a family member or themselves going through a mental health challenge or battle or disease. And so now that has shifted. We're much more confident in our ability to share with other people. And it's taken a really broad approach to normalize those conversations and to reduce that stigma. So it's less of a historical answer on why we have it around end of life and more of a hope answer on what this could become based on what we've seen when it comes to mental illness and the ability for us to have conversations and to move forward as a society in an awareness and advocacy, a component of vulnerability for ourselves and others. And that's ultimately, it's not the same playbook, but I think that's ultimately where I hope this end of life type of conversation will go.
I think I would agree with that. I think through the generations we've seen, we saw this big push to be all you can be and do everything you want to do and don't let anything set you back. And I think we're starting to get as a society to this place where we say, all the feelings are okay. Let's talk about this. It's okay to say no and not do everything that you think you should be doing, which is really very hopeful. And it's kind of interesting to me when you stop and you look back and, I was raised thinking that there were very right things and there were very wrong things, and that was it, right? And the older I get, I realize there are a whole bunch of gray in everything. If you stop and you think about it, you can identify kind of the hope and the beauty in it. And so to see that pendulum go, like I grew up always being told, have a stiff upper lip, don't cry, don't be upset. And to then see and work with students and encouraging them and hearing them encourage each other to share those feelings and share those experiences. I'm hoping that openness and that acceptance will really stretch to the end of life decision-making realm so that people do talk and they are understanding and hopeful.
I appreciate ending on that note, that moment of hope, that note of hope. It has been delightful to hear from each of you. The threads that have gone through your presentations have enriched each other. So I just am really grateful for you spending time with us and diving into this hard conversation, but giving us some hope and some tools for maybe having these conversations, either professionally, depending on our profession, or in our own families and with our own selves. So that has brought us to the end of this time. Folks who are watching, you're welcome to take a little break. And at 3:40, the next group will come on. And the topic is collective resilience, addressing community violence through cross-system collaboration. So there'll be a variety of speakers on that. So once again, thank you so much to our three panelists. And thank you all for joining us for this really important conversation. Have a great day.